Hello, everyone, and welcome. I am Julie Houston, Director of Global Chapter Operations at IAOP, and I thank you for joining our Southern California Digital and Healthcare Chapters joint webinar today. Today's agenda includes a brief review of IAOP, a snapshot of the chapters that are involved in the session, and then we'll move into the program content and panel discussion. For those of you who may not be familiar with IAOP, we are the association with collaboration at its core. We bring customers, providers, and advisors together in collaborative, knowledge-based environments to promote professional and organizational development. With the changes in today's outsourcing operational models, we provide a uniquely diverse environment where individuals and organizations can share their knowledge and passion about the industry with one another and improve their outsourcing outcomes. Members of IAOP receive numerous benefits, some of which are participation in our new member-only community, Connect IAOP, our global chapter network, training and certifications that are considered top in the industry, and discounted pricing to our world-renowned conferences and events, such as the Outsourcing World Summit. They also receive receipt of our renowned publication Pulse, access to our online repository, firmbuilder.com, and discounted pricing to the risk management tool Supply Wisdom. We recognize leaders within the industry through our award programs, such as the Global Outsourcing 100, which recognizes providers and advisors, the Global Excellence in Outsourcing Award, or GO Award, which recognizes customer teams, the Hall of Fame Award, which recognizes individuals for their contributions to the industry, and the Gauchrio Award, which recognizes the integration of corporate social responsibility. Nomination and application processes are outlined on our website, and I would encourage you to take a look. We have some upcoming chapter meetings. If you're going to be in the Nordic region, they have an in-person meeting taking place on February 2nd. We have another webinar planned with our Global Human Capital chapter on February 4th. And our UK and Ireland chapter will be holding their next meeting on February 24th. In addition, we have the chapter meet and greet. If you're attending the Outsourcing World Summit, I would encourage you to come and network with our chapter leadership teams and find out more about their plans for 2016. Speaking of the Outsourcing World Summit, if you have not already registered, there is still time to join us, and I would encourage you to do so. There are valuable workshops and networking opportunities packed into this program that you won't want to miss. So go to our website and be sure to register. And lastly, I would like to make you aware of our COP Masterclass schedules. We have a class in March taking place in Georgia, a class in May in Ontario, a couple of classes in the Netherlands, one in May and one in September, a class in Chicago, and then a class in Colorado in September. So take a look at the website and be sure to register for these master classes and get your COP certification. Before I turn the program over to our host for today, one of the digital chapter team members, Andy Popoff, a principal with Avasant, I'd like to cover a couple of quick housekeeping items with regard to how we will handle questions. All of the lines have been muted to maintain a high level of sound quality, so we will use the chat box on the left-hand side of your screen for questions. You may pose your questions at any point during the program. It will be monitored and questions will be addressed at the appropriate time. And I think at this point, I'm ready to turn things over to Andy. Andy?
Thank you, Julie. Appreciate the introduction. Just to give you a quick overview of the webinar today, we have two exciting speakers telling us about Accelerating Digital Transformation in Healthcare. The first speaker we have today is Jim McDonnell, the GM at Cisco. And Dr. Sawyer is joining us from the University of California of San Francisco from the Center of Digital Health Innovation. And following those two presentations, we'll have an exciting panel that Joe Hogan will host. Julie, if you could move to the next slide. Today's webinar is brought to you by three chapters: the Digital Enterprise chapter, the Southern California chapter, and the Healthcare Industry chapter. And the objective of all three chapters is to share leading-edge insights and concepts and share best practices and explore new horizons. And then, of course, hopefully enable networking and building of relationships. So hopefully we can make this exciting and interactive for all of you. With no further ado, I'd like to introduce today's speakers. The first one is Jim McDonnell of Cisco. He's the General Manager of Service Integration Technology. And following his presentation will be Dr. Sawyer from the University of California, San Francisco, who's an Associate Director at the Center of Digital Health Innovation. With no further ado, let me pass on to Jim.
Great, thanks, Andy. I appreciate it very much, and thank you all for attending today. Great opportunity to talk to you about an area where we think there's just a huge amount of opportunity and an acceleration really already occurring in the market with respect to digital in the healthcare space. It's certainly not the only industry undergoing massive transformation. In fact, many ways, we believe that it's an industry that maybe has lagged behind. In fact, one of the very few industries on the planet that's experienced negative productivity over a very protracted period of time. But we think the time is right now to really accelerate the use of digital in healthcare, and we'll talk to you today about some of the ways that we see opportunities. One of the things that's interesting, if you look at what's happening across the digitization of other industries, and in particular, if you look at more holistically how those come together, for example, at a city or even country level, there's a tremendous amount of intersection between, first of all, what we can learn and how other industries have transformed through digital, as well as, frankly, through some of the capabilities that are enabled through things like digital cities, the kinds of sensor-based data that can come out that can help really, from a healthcare perspective, in managing the process on an integrated basis. There's really two elements to this from a technology perspective that Cisco believes are really key to understand. The first is, how do you sort of grapple with the proliferation of the data that's occurring at a really massive rate right now? More importantly, how do you really derive meaningful insights from that data? Not just collecting the data, but actually determining, what does it really tell you? And then, very importantly, what do you do with that information? How do you translate that into action and drive automation? And what's very different, I think, today than maybe just even a few years ago, and this is the example we show here is more out of an automotive industry, but the same exact model applies across multiple industries and maybe nowhere more than in healthcare, which is it really is a very highly fractured model that we operate in today with different pools of data that are aggregated and collected in various sources. And in fact, as we'll talk to you about in healthcare, those data sources are now coming from devices that may be, wearable devices at a consumer level. They could be coming from other healthcare providers and so forth. So the data is really spread out across a significant number of disparate sets of sources. And one of the great challenges then in terms of digitizing is how do I really wrestle with all that data, pull it together in a way that it's meaningful, and then decide what action that I want to take from that. And really, this has been an evolution. I apologize. This slide doesn't show it as well as it could, but it really is sort of the evolution from a very client-server, first server-based to a client-server-based, but really now we're operating at web scale. And again, as you look at what's happening in healthcare in particular, nowhere is the amount of innovation in terms of new technologies running at the edge. In the case of healthcare, often the edge is the patient themselves. And how does that really integrate into the context of providing care to that patient? So just a little bit of context. I mean, why is Cisco telling this story? Well, Cisco actually is really its highest area of growth today is in software, and in particular software focused at these challenges around digitization and data and analytics. a number of acquisitions, a fairly significant number of Cisco engineers working in the area. And actually, if you look at Cisco's businesses and broke them out, we would be, as a standalone company, the 5th largest software company on the planet. So we have a very significant heritage, not only in terms of data from a networking point of view, but increasingly in terms of how you understand and manage that data. So with that, I'm going to turn it over to Dr. Sawyer to talk about the experiences we've worked through together in terms of interoperability. So Dr. Sawyer?
Yeah, hi, this is Einar Sawyer. Can you hear my mic okay?
Yes.
Sounds good.
Thank you. So I'm an orthopedist at University of California, San Francisco, but my other role I get to play is in digital health innovation and health technology innovation. So I'm the Associate Director for Strategic Relations at the Center for Digital Health Innovation and have had a great opportunity to work in strategic alliances and really very fortunate to have recently been working on a partnership with Cisco to truly transform healthcare by providing a comprehensive interoperability platform. And what I'd like to do is pick up here where Jim was leading to, is that this concept of interoperability in healthcare is one that people assume we already have, but it truly is the #1 challenge in health information and actually healthcare delivery that we have today. People move in and out of states of wellness and illness, and their bodies move freely from point to point as they touch different intersections on their health sphere and generate new data, whether it's at the lab or whether it's at the gym or whether it's at the doctor's office or an ER in a different city. Their bodies move from point to point, but their data doesn't. And this causes tremendous interoperability gaps in the health information flow. These gaps have been attributed with massive amounts of funding loss, let alone the morbidity and mortality, the consequences of lack of information at the right time. Just looking at a simple example, such as gaps in the interoperability chain of pharmaceutical information, that $300 billion a year are attributed to that interoperability gap alone. 200,000 deaths a year are, we think, preventable if the information that was available somewhere was available at the moment of decision making, whether that was by a patient, a family member, or a provider. So these are profound consequences, and such that the government actually took notice of this and put forth a publication from the Office of the National Coordinator in 2014 and called this an urgent national priority. And basically, in the fall of 2014, identified in a beautiful document, which I would recommend to any of you to look at, the fact that we can't move information in a way that a patient needs it, a provider needs it, a hospital needs it, even the other stakeholders, insurance companies and researchers. We're not moving information in a way that would be very effective in cost and care. So they call this a national priority, and they said there's no better time than now. And then what I thought was very interesting in the document is that they thought that maybe by 2024 they would have the right infrastructure in place to do this. From a healthcare delivery standpoint and a patient and family member standpoint, we feel that's way too long. We can't really wait a decade. And in fact, there are several forces at work that are moving us rapidly in a direction where interoperability in healthcare has to be a priority. One is that we have unprecedented amounts of data, of health information, like we've never had before, truly in other industries. It's extremely exciting. It's coming from inside the clinical care system, where we've had information in terms of health information, but also device information that we've for years struggled to intersect and have been trying to brute force our health IT systems inside hospitals for over a decade here at UCSF. But we also now have an unprecedented amount of data coming from outside the clinical care system. So some of these represent remote devices. It's very exciting that we're able to push evaluation and communication about health further outside the clinical setting. And patients are becoming more empowered with wearables and the culture of wanting to assess and make decisions on their own. The problem is a lot of these devices are not validated. Some of the consumer wearables are not validated, but even those that are, in those that are medical grade devices on the outside. The problem we have as care providers is as more of these devices exist outside and capabilities exist for health information to be communicated from outside the clinical system into the system, there's this false expectation that's arisen that we will be, as physicians or providers or caregivers, be waiting 24/7 for that information to come to us, so then we can act on it or give you guidance, and we can then have a very well connected and responsive system. But that's the false expectation. That's the fairy tale. And it probably arose out of other industries where when there are sensing devices and communication systems that are developed, they're usually integrated much more readily than they've been in healthcare. The reality is that the physicians are more feeling like this. So it's exciting that all this information is available, but our problem is, first of all, how much of that information do we really need? How does that information get filtered and contextualized so that we can actually make good recommendations back to you? The other reality is that certainly we're not able to assimilate that information 24/7, as is sometimes the expectation as we move some of these systems further outside the clinical setting. But it's nonetheless extremely exciting. So I really would love to be able to create much better use of the information, as would patients, providers, and all stakeholders around the sphere. So we would love to get closer to what we call informed living, where the information that's available or attainable could be contextualized and then moved to the point of decision making and made actionable. So in pursuit of that, we felt like we needed to find a joint venture between the understandings we had on the front lines of healthcare and our own simple brute forcing of integrating our health IT systems, which were not scalable. We needed to marry that to another industry that had tremendous capacity and had already demonstrated capabilities in end-to-end data journeys. And as we searched through, we found that probably there was no better partner for this than Cisco, based on all the things they've demonstrated in other arenas. So we're very excited about this partnership to join and create a comprehensive health interoperability platform. You probably know Cisco very well. It's a global company with a massive history and track record for success in communication and delivering information at the right moment. You might not know much about UCSF, so just for a couple of minutes, I'll give you some background. We are typically a year-to-year #1 research-funded, government research, NIH-funded academic medical center in the country, and we have multiple layers of different professional schools that we offer. We also have an innovation track record that extends way back early on in discovery and then dissemination of discovery back as far as our early years, 150 years ago, but more recently, you've probably heard a lot of things spinning out of UCSF in terms of life sciences, so diagnostics, therapeutics, and device, and recently in digital health innovation. And we have seeded a lot of the startups in our own local region here. In any one moment, we have 12 to 1,500 representatives, whether they're providers or researchers or innovators around the world. So we have a large global outreach program as well. And we have won a few prizes for some of the innovative and discovery work that we've done here. It's a large enterprise system, $22 billion in annual revenue across the entire UC system. But within the healthcare system alone, it's7.5 billion. And I only point that out because it's just showing the scope of impact we have, at least in the state of California, in terms of we cover a third of the lives in California. We touch a third of the lives in California from a healthcare standpoint. We've also been able to integrate our records, clinical and research records, and working very hard to make those available across the system for those learnings that can happen on larger scale. So about 14 million records available to us. And we have been innovating for quite a while, and more recently we noticed a rapid uptick in innovation in health information and in digital health. And so over the last 4 or 5 years, there were many frontline innovators working hard to solve problems that they were experiencing every day or they were witnessing in their patients. And we do a really good job of conceptualizing solutions that fit into the workflow or where the workflow has to be disrupted as well. The other strength we bring as frontline innovators is we know we have to use these things, so we want them to work, and we'll do proof of concept and evaluation all the way across the arc of development, because we're really dedicated to showing effectiveness in care and cost. But again, it's very hard to navigate getting from project to product. And we don't like these successful ideas that have evidence behind them by the time we've gotten through the grant. We don't want them to end there and just die at the end of the grant. We really want to scale them up and out of the university. We do that very successfully, but it's hard to navigate that process. So we created the Center for Digital Health Innovation, partly to support the frontline innovation and dissemination that was going on, but also to support validation of internal and external solutions that were being built. And we also realized that integration was a key component of making all of these things useful, rather than siloed solutions. And of course, education is important to us to create problem solvers, not just things. But as we worked harder and harder at these things, we realized that the real rate limiting step to transforming healthcare was really around the inability to connect the information from whether it was a device that was being developed or whether it was health information deep in the data science world. We needed to get the information aggregated in ways we hadn't been able to do. And so we came up with the concept that we had to focus quite a bit of our energy into integration and interoperability. But again, our patchwork methodology wasn't going to work. So this is where we worked very hard to find the right partner and develop a conversation with Cisco about what teachings they had from other industries, what technologies did they have. We showed our problems to them, and they said, we've seen that before, and we've seen that before, and in fact, we actually have a solution there. Or if we aggregate our solutions and we have them informed by your problems and then your ability to test them, we can really solve a massive problem in healthcare. So we have worked hard to create this partnership, and we've now launched a co-location model where their engineers work closely with our researchers, our clinicians, our informaticists, and are working on solving very specific problems initially laid out and identified beautifully in the ONC document, and in several large categories that are really limiting healthcare. And we call this concept informed health. And that's the idea of having the right information at the right instance to get the best decision and best outcome. We do this in other parts of our lives, whether it's just getting across town or booking an airline. But in healthcare, we don't have the right information at the right moment for many of the decisions that are made, even if that information is right nearby in another facility. So this solution, the way we're working on it is we certainly are being responsive to the seismic shifts that are happening in healthcare in the US, but also around the world, moving more towards value-based from volume-based, more towards collaborative models, more towards patient empowerment and looking at information that's generated outside the clinical system and integrating that with information inside the clinical system, and then empowering that by having all stakeholders weighing in. So this is meant to be a universally informed but universally applicable platform. And we also want this to fit well into this new era that most industries are experiencing of this highly distributed healthcare model and hyper distributed as well in terms of global. So we're focusing initially, you can imagine the interoperability gaps are enormous. We've put them into 7 or 8 large buckets, but we want to focus in on some core areas. One being around collaborative care delivery. And if you look at the closed systems like Kaiser, Geisinger, Intermountain, et cetera, you would think because they're integrated services that they already have very integrated IT. Some, yes, and certainly big gaps still exist. But that model is being disseminated more broadly across healthcare as we shift into ACO models and shared risk and shared responsibility. And then in addition, we're seeing these systems aggregating. And so the amount of information that needs to be exchanged across different healthcare systems between different EHRs, different providers, or patients who move about the different areas and generate data, there are massive needs, and for the interoperability platform, massive opportunities in exchanging data in a meaningful way across these aggregated systems. And the chronic disease management section is a very important piece to us, because we realize that chronic disease is not only significant in our country and across the world, but much of it can be modified and can be impacted greatly if we could improve communication across the system and also incentivize healthy lifestyle choices. So we're looking at a very big focus on end-to-end data journeys in chronic disease management, extending all the way from prevention to end of life. And there are some very nice solutions that are isolated in sections across that journey. And we're going to try to focus really hard on how do we integrate those pieces. So if you look at prevention programs intersecting with early diagnostic and intervention programs, focused on programs in hospital, like the cardiac care that's given in a hospital, intersecting that with cardiac rehab programs, and ultimately, as patients' course deteriorates, moving into palliative care and end of life. So you can imagine stringing all of those solutions together and letting the information flow freely as patients are moving back and forth on those continuums. And then finally, we also want to intersect the efforts around precision medicine, which is a very exciting shift in healthcare. And it's moving more from just population-based information being applied to individuals to actually understanding that individual's information in terms of their genomics, their phenomics, their biomes. And as we move more into using consumer analytics, there's a category I'm now calling the phonome, because we can get data from patients' activity patterns that are telling us not just activity, but shopping, cell phone usage. When associated with specific clinical data we have, we're finding that we can do some very early detection, particularly in areas that have been demonstrated around depression as a fine example. So Jim, I'll flip this over to you, but I'll just, from the provider side, our fantasy would be that we can aggregate information in a meaningful way, pull information from disparate data sources, whether they're wearables or apps on the consumer side, whether they're home monitoring systems, whether they're monitoring systems deep inside the hospital, integrate that with clinical information, patient-reported information, lab and imaging information, and also be able to flex that across different systems wherever the patient is moving and the information is needed. So this is a diagram that's quite expansive, but the goal would be that we have a system that is responsive to all stakeholders around the sphere of healthcare, and that the purpose and the design of this system will be function-driven and patient-centered. And I'm going to let Jim take over here and speak more on the technology side. That's actually from the care delivery wish list.
Great, thank you, Dr. Story, and you said it perfectly. I mean, the whole concept here is that there's a broad ecosystem required to solve this problem. It's not something that UCSF and Cisco alone can go solve. And so, if you look at the left there, it's just an example, but there's a huge number of sources of data and applications that are being developed, as Dr. Sawyer referenced, that really have the opportunity to have broad impact. The impact today is fairly limited because they can typically reach a very narrow audience. And so, we want them to be an integral part of this ecosystem. You have on the right, of course, a very large number of different participants in the process. It's certainly the big providers, big and small providers, the government provider organizations, the payers, and so forth. Pharmaceutical certainly would fit in there. So a lot of participants in the process. Again, we want to have seamlessly integrated into this end-to-end data journey. And then on the top, you see these modules. Again, a lot of the innovation that's occurring in this space is occurring by the frontline innovators, as Dr. Sawyer identified. And so we want to empower them to take the innovations they're developing and really bring them into a much broader audience. Because one of the great challenges with taking these innovations into a provider organization is, how do I integrate it into my workflow? How do I make it a part of my process, which is different from the provider process down the road? And so this platform is really intended to enable that. You see I won't go through a lot of details on the technology, but certainly a big focus on data, how you integrate applications, and then of course, we need to be very sensitive to security and privacy and access controls. So that'll be a big part of what we're focused on. And then finally, and I think this is our last slide, and we'll hand it over for questions and panel discussion. But finally, just in terms of the integration, very focused, as we mentioned, around the devices, the growth of consumer devices, certainly, but the proliferation of medical grade devices and the surprising fact that, many of them are not connected into the hospital networks and hospital systems. There's a proliferation of innovation occurring in the space, and we want to incorporate that into this process. And then, of course, very importantly, the EHR, ever present and very important to integrate into. But ultimately, as you see on the left there, just the stack of technologies needed to support this. And the concept here is really to make this highly modular, as Dr. Sawyer referenced, very use case and functional driven. So, depending on what challenge the particular healthcare provider system is trying to solve for, let's implement the elements of the platform that solve for that problem. I think one of the key challenges in sort of digitizing any industry, but again, I would say in no industry it's more pronounced than in healthcare, is picking the challenges that you want to address. It's not, I think, a wise strategy to try to solve all problems with one fell swoop. And so, although we're architecting this as an integrated platform, we want to make sure that we can go in and implement the components that solve for the problems that particular providers have. So with that, I think we're going to shift over. I'm sorry, we talked a little bit of the model, just to close on this, and then shift to panel. As Dr. Sawyer indicated, we're taking a collaborative model, so it's co-located engineers between Cisco and UCSF on the UCSF campus in Mission Bay in San Francisco. A rapid development model. Again, I would suggest to the listeners here today that a model built on taking the source of innovation and the technology needed to enable that and co-locating that is a model that we've seen work very successfully in other industries, and we think will help us accelerate our ability to get to market, and then the ability really to operate not just in a lab environment that is disconnected from reality, but actually in this living laboratory where we have access to the clinicians that are caring for their patients and the technology that we can use to better enable them. So with that, I'm going to turn it over to Joe, and I think we'll open up and ask some questions. So Joe, over to you.
Thank you very, very much, Jim. And Dr. Sawyer, thank you very much for your insights and the sharing of that information. What we want to begin now is a panel discussion, and we want to invite, as you can see from the chart here, Dr. Sawyer and Jim to be part of that discussion with us. Also, our host, Andy Popov, who is Avasant Principal for Digital Technologies throughout the world. In fact, Andy, I believe you're speaking to us today from Dubai, if I'm not mistaken. And then also joining us will be Sri Bengala, and Sri is also an Avasant Fellow and the former CIO at Forest Laboratories. So I think it's a very distinguished panel. Sri, would you like to say hello to the folks? They haven't heard your voice yet, so they know what you sound like.
Yeah, hi, this is Srinivas Mangala.
Okay, great. Dr. Sawyer, I'd like to start, as we're waiting for some of the questions to come in, I'd like to start with you as a practitioner and also as a leader in the digital space here. What would be your advice to an individual such as myself or such as anybody listening on the call to take ownership of their healthcare in a digital way? How can we actually affect that change? Because a lot of times, we're talking about, all the switches and everything else from Cisco and all the software. How can we make sure that we get what we need?
Well, that's a really good question. I think that the main thing to establish, first of all, is really good communication with your care team or your primary care provider, and establish a dialogue that you are very interested in being empowered. And what we're seeing now from both sides of that equation is much more of team decision making, and both parties wanting the other to have as much information as possible about them that could impact the recommendations given or the choices made by the patient. So first of all, just creating a dialogue and a tone that says, I really want to be a very active role in my health and my healthcare. And then most providers now are really embracing that and looking for ways to help empower their patients. So for me, for instance, I'll be looking for ways to provide you the information you need, whether it's through the MyChart portal in your legacy medical record system at our facility, or helping you to facilitate tools that will allow you to get information from other care areas, showing you ways where you can combine them into a record for yourself. And this is another service that we're going to be providing through this platform, is the ability for patients to access information from disparate sources. But the ability for you to actually get, when you need it, the information that you need. And I guess finally, we're seeing patients who come in at very different levels around how much they want to embrace technology. And for us, we innovate in personnel, process, and technology. We want to actually customize the solution or the recommendation to that individual. And you sound like you would be very interested in the new technologies available, and we'd be interested in talking to you about how do they fit into your workflow, what are your capabilities for managing the types of solutions that we could recommend to you. I think it's very much about personalizing the intervention to you, so that starts back at the communication level.
Very good, Doctor. Thank you. Thank you very much. Jim, a question coming to you as we're getting a few questions here. But one thought that I had as you're describing Cisco's experience, how did this come about, this relationship with USFF? I'm sorry, UCSF. My bifocals are messing up as I look at the screen. How did this come about? Was this something that UCSF came out and sought out Cisco, or was this an idea that came up in the laboratories of Cisco? Do you have any idea how it all occurred?
Absolutely. No, it is. So it came up really because of Dr. Sawyer and in some senses quite by chance, I would say, and I'll ask her to comment as well. But actually, we happened to meet in a forum on another project that Cisco and UCSF were working on, and she began to describe one of the initiatives in the Center for Digital Health Innovation around interoperability, and we began to talk about some of what Cisco has built and bought over the past couple of years, and that conversation continued over the course of a few weeks and a couple of months, and with each conversation, it seemed like there was more and more alignment between the challenge that the center was trying to solve around interoperability and some of the capabilities that Cisco had built out. So really, Dr. Sawyer has taken the lead on this and really driven the conversation forward and expanded it obviously very broadly across UCSF and the UC system, and then we've gotten a broader Cisco team involved, ultimately culminating in a fairly landmark partnership agreement signed in September. So, but it took probably about a year to get to that point, because we really it was very important for both parties that we were really certain that we were serious about taking on this big challenge. As Dr. Sawyer indicated, this is a monumental challenge. I mean, the cost consequences alone, just in the United States, are astronomical, let alone, obviously, the consequences to patient care. And so we wanted to be sure on both sides that we were really, really deadly serious about taking on this challenge and solving it in a way that will impact the industry. So it's been a great experience for me personally, just having had the opportunity to work with so many incredible innovators at UCSF, which is just an amazing source of innovation and people with such great talent. And then the ability to co-locate is just, I think, a phenomenal way to accelerate. So it's quite a journey. And again, I would just suggest digitization is not for the faint of heart. I mean, it really is a very serious undertaking in any industry. No one more than healthcare. So.
Definitely. Sri, great answer, Jim. Absolutely great answer, because like you say, it's a journey, not the destination. And beginning to digitize, you're also assuming that out in the real world, there are people that are going to be able to use this or not use this based on their varying degrees of capability and understanding how to make use of the value. Which kind of brings me to my next question. Sri, you know, as an Avison Fellow for Healthcare and Pharmaceuticals, and also as a former CIO for Forest Laboratories, how do you see something like this, you know, coming about in the industry, and what would be your recommendation to get other people involved, or how to get people linked up to be able to make this a value? It's one thing to have it in relationship to your own personal health care, but how do you pull all the data in about, you know, the prescription drugs? How do you pull all the data in about, you know, the physiological data? People, you know, every day now we're all wearing Fitbits and, you know, all sorts of watches to track our hearts, to track our paces, you know, et cetera. What do you think about that? What do you think, you know, some of the best ways are to approach this? Do we form a consortium, or what do we do?
Yeah, so to a certain extent, I think what you know, Jim and Dr. Sawyer described, I think that's essentially a first step in this. And as I had discussed with Dr. Sawyer early on in a prior discussion, I think the success of an initiative like this is going to depend significantly on participation from all the stakeholders in this healthcare continuum. I think Dr. Sawyer had touched on quite a few of them. That would be, you know, all forms of providers, both private and, you know, federal or state funded providers, all payers, all life science companies, whether they be diagnostic, you know, companies or vaccine companies, biologics or pharmaceutical. And frankly, I also think in addition to the patient population, it's also the caregivers. There are many disease states in which I think more than the patient, it's the caregiver who gets, you know, engaged in this process, specifically based on disease states and or condition of a patient. And then, of course, there are all of these patient advocacy groups or, you know, healthcare advocacy groups. I think all of these have to collaborate. Having said that, I think you all heard what Jim said, which is this is almost like a boil the ocean phenomenon. So you have to figure out how you start small, where you can first demonstrate that this process works, boiling hopefully a cup at a time, and then begin to expand it. Now you touched on something else, Joe, which is this whole advent of wearables and or personal devices, which are also becoming data collection devices. There again, I think that Dr. Sawyer had mentioned something that I think is very important, which is to have mechanisms to validate those data collection devices such that the information that's collected, when aggregated, along with information sources from EHRs, from providers, you know, claims data from payers, or even clinical trials databases from life sciences companies, that you can have some measure of confidence in that information so that when a provider or a healthcare professional like a physician is trying to assess and make a decision, that there is confidence in the data, not a question about it. Now, I've touched on this more from a process and ownership or a stakeholder standpoint. There's this whole technical underpinning behind this as well. And I think that, you know, Cisco should be commended for making this investment in, you know, I hate to use this phrase, but if you build it, they will come kind of a phenomenon. But to a certain extent, this is something that needs to expand beyond just one technical platform if it has to have adoption from all the stakeholders in this continuum. And it's not just in the U.S., because to the point that Dr. Sawyer made, increasingly you find it's not patients just moving around within the country, but patients who are going to be moving outside the country as well. How do they then take their information to not just one hospital on the East Coast to the West Coast, et cetera, but beyond and outside the country as well?
That's a good point. But, you know, what I would open it up to, I don't know if Andy is still with us, but if he's not, I'd like to ask him, and if he's not here, Dr. Sawyer, I'd like to ask you to step in for him.
Sure.
I'm kind of a simple guy. And, you know, when I look at all the massive digitization and all of the change, when my mother-in-law or an elderly person goes into their physician today, that experience is going to change. What's the sensitivity to be able to work with those kind of folks to make sure that they really understand what's going on? You know, because all of a sudden, you know, you're going from paper to digitization. You're pulling in information that, you know, it's almost kind of becoming a little bit too clinical when a patient shows up. And folks like that are a little bit more to the, I guess a better way to put it, are just a little bit more comfortable with the human touch. You know, Dr. Sawyer, have you had people bring these kind of issues up to you?
Yeah, and I think that's, you know, we talk a lot about, and Jim alluded to it too, that technology is a part of what's enabling us to deliver better care. But we definitely want it to be in context with the individual, with their preferences, with their own either intellectual or IT infrastructure in their house. So always contextualizing this back to the patient, always making any of these innovations, particularly something of this scale, to be focused on the patient and the individual and improving their lives. And obviously that will have a halo effect across the entire culture. But again, back to tailoring it to the individual that's involved. The good news is that despite their reputation, the most rapidly adopting group of technology right now are the geriatric patients. They're not the highest in absolute number, but they're most rapidly adopting. One of the biggest groups of users, as Srinivas pointed out, are caregivers. They're highly motivated to leverage any technology or any solution that lets them do a better job of caregiving. So in the area of geriatrics, we are extremely busy, not just UCSF. When I say we, people who are in health innovation, that's a very, very busy space. Not only is it the biggest growing demographic, but with the highest healthcare costs, but the opportunities there are enormous, and more care is being shifted to caring for people through end of life in their homes. And if we can leverage technology with the life flow, I call it, instead of workflow, we can actually find a great adoption, because people aren't in any age aren't necessarily looking for a technology. They're looking for a solution. They're looking for how it makes their life better. And so if that stays the focus, I think it drives us in the right direction. I'm going to take one opportunity here and jump back at what Srinivas was talking about, because it's really important to understand that this is an open platform. So it's this nidus of the partnership was UCSF and Cisco, but we are rapidly bringing on strategic partners and circles of alliances around this so that it's a universally informed and universally applicable solution. And I think it's a really important point that Srinivas was alluding to, because it's certainly not meant to be a solution that just fits for UCSF. We found the challenges in health interoperability gaps to be absolutely limiting care, productivity, efficiency, revenues, everything. So we build little bridges. But we're not uniquely smart. Every healthcare delivery system is fighting the same fight. And what we found was that our solutions maybe solved our problem but couldn't scale. So we've turned to Cisco now to help us create a scalable solution.
Hey, Joe, this is Srinivas. Real quickly to add on to something that Dr. Sawyer said, just to take a slightly different perspective on this, I think to the question you asked earlier, the hope is that with the advent of digitization and, let me say smart adoption of technology in the healthcare arena, that the physician-patient interaction will be helped, meaning there'll be more time available for patient-physician interaction and that communication which patients were used to in the past. So that's one issue, one positive outcome that we're looking for. The second is that with information available, as Dr. Sawyer had pointed out, as an as-needed basis, there's the likelihood of spreading the load. And what I mean by that is it shouldn't be that the physician is always collecting all the information from the patient at the point of contact. It could be that a secondary caregiver, like a nurse or a nurse's assistant, could be making certain decisions if information was available and standards of care were defined appropriately. And technology can assist in that as well. It can also help in triaging and making sure that the physician and or the provider networks are able to focus on the more critical care aspects first, because that is another area of additional cost to the whole overall system.
So there's a question I would like all three of you. Go ahead. Somebody was
just speak. Extremely valuable points, Srinivas, because one thing is the technology should disappear. It should be seamless behind the scenes, and pretty soon we won't call it digital health. It'll just be the medium that we give healthcare in, or that we choose health in our lives. The other is that we are going to be constantly seeking those places of where a person needs high touch or low touch. And it's different for different people, those who can be more self-empowered versus those who are really dependent. But like you were saying, there will always be a place for the hands-on in-person, but there are lots of efficiencies to be gained by being able to push care to a more independent and outside the clinical system area and leverage technology to enable that.
I think it's a great point. I think, one question I would have for all three of you, how, when you talk about healthcare, you talk about individual's health. I mean, it's a built-in value proposition that a doctor has when he treats a patient. It's a built-in value proposition when you have the proper drugs, to reduce cholesterol or to help with managing your cancer, et cetera. So most of that value proposition is really dealt with survival. But as we apply all of this technology, as we apply all of this digitization, is this going to increase the cost of healthcare or decrease the cost of healthcare? Because that's another debate that goes on around the world is, the more better we make it, do we make it more expensive? And by making it more expensive, do we make it more unaffordable for the people that really need it?
So I can I'll open up on that and then turn over to my colleagues. Absolutely, make care more affordable. And one of the things I would just tell you in terms of working with the amazing innovators at UCSF is, who are largely the frontline enterprise, the clinicians, is their laser focus on how do they cost effectively deliver care. Right? It's all about the patient outcome combined with the effectiveness and efficiency of what they do day to day. So I think it's absolutely vital, and one of the absolute requirements of the platform is that it make economic sense, because we are going to be asking for investments from the providers to buy this platform. And so if we can articulate exactly what this does in terms of making them more efficient at what they do, as I said, I think it's 30 years in a row the healthcare industry has had negative productivity, the only industry in history that suffered, that kind of a track record. It's absolutely vital to enable a productive, a positive productivity trend.
Yeah, because it's a negative productivity trend with a ever-growing cost curve trend to the consumer.
So there's something key over here, Joe, I think that should be mentioned. I think that a lot of this digitization, et cetera, is being driven, I hate to say this, not so much by the industry itself initially, but more by certain regulations, including what is called the Affordable Care Act, and some assessment that happened even prior to that, where the whole industry, particularly in the United States, was a fee-for-service basis. Essentially, what that meant is that all compensation for healthcare was based on the number of services provided. And partly what's happening here, and part of the reason that digitization is being brought in and is being adopted at the rate that it is today, is to move away from fee-for-service and move more towards an outcomes-based, the patient's improved outcomes measure. So when you say that, is this going to make things more expensive? My belief is that if this is done right, and, I can't stress that if this is done right, more, it should bring the overall cost of care down. But more importantly, there should be a link between the money spent or the investment made to the patient outcome or the improvement in patient outcomes. I think that's something that we didn't mention that in this conversation, so I just wanted to make sure we point that out.
Good. Excellent.
I think it's extremely important to stay focused on the triple aims, which is better care to more people at lower cost. And I think both Jim and Srinivas pointed out some really good things. And one I want to really get back on is we should not be adding cost to the healthcare system. And unless we're incorporating a couple of principles, we could be at risk for doing that. So one principle we work hard on is making sure that the solution we're building is informed and even designed in part by the user and by the stakeholders who will either influence it or be impacted by it. Because then we know we're going for the right problem as we're designing this, and that it's going to be designed in a way that it will actually solve those problems. And the other point I wanted to bring out is you need to do evaluation all the way along the way. Continue to challenge yourself to demonstrate effectiveness in care and cost, both of those items linked. And so to your question, I think it's on us to say, what's the ROI and how soon will it be demonstrated? Because otherwise we're going to continue to build things that either miss targets or they actually add cost to the system. And that is absolutely front and center on our minds right now. We are going after better care for more people at lower cost.
Thank you. Okay, we have time for probably one more question. We're coming up towards the bottom of the hour. And I would just, in a word from each one of you, I'd like to ask is, what do you see or what do you think we need to be doing with regard to security as we begin to blend all of this data? That also seems to be a mountain to tackle. Jim, I'd like to start with you.
Sure. I mean, I think it just has to be, absolutely foundational. Clearly, and by the way, it's a very complex problem as you go outside the United States because of the, regulations country by country vary. There's a lot of data sovereignty concerns. And so absolutely, the users, the consumer and the providers need to be absolutely certain that they don't have to worry about that, right? So that's got to be job one. I think if you deploy this in a way that you haven't built that from the ground up, you're not going to succeed.
Good point. So we're running out of time right now. What I'd like to do is just kind of end this pretty quickly and just say thank you to our panel, to Sri, to Andy, to Jim, and Dr. Sawyer. Thank you so much for your insights and what you're sharing, and the effort that's going on there at UCSF. And hopefully it'll make the planet a little bit better for all of us. So with that, I'd like to turn it back over to Julie. Thank you all.
Thanks, Joe. I just wanted to say thank you as well from on behalf of IAOP and all of the chapters that are involved. And thank you to Joe for a great moderation, for a fantastic job of moderating the panel discussion. And I appreciate all of the insight from all of the panelists. And I hope that you will join us again for our next program. Thanks to everyone. Have a fantastic afternoon or evening, and we'll talk to you soon.
Thanks, everybody.
Thank you, everybody.
Thank you.
Bye-bye. Thank you.